It's okay, sir. Thank you, sir, for joining. Divakant, please over to you.
Okay, thank you so much. So we welcome all of you to this very exciting session that Dr. Ashraful and our team had planned. So we decided to base it on the cricket theme. So we have a regular similar themes in India that has been happening with the Ophthalmic Premier League. So we wanted to base it on it. So the basic format will be such that we have one speaker each or one player each from both the teams, that is the Bangladesh team and the Indian team. And each will go into the field on a debate, and each debate will be judged by an umpire. So we have a mix of young and senior faculty as umpires with us. And after each talk, they will give their decision whether the person is out or not out. And then the decision will go to all our three third umpires. So either they can choose to go with the decision of the umpire or give their own decision or their own comment if they feel it's required as well. And to decide which team will go first, Dr. Ashraful and I will do a toss for that. So, Dr. Ashraful, you have the introduce.
Divakant, do you think that all the three third umpire will say with all the team?
Just decision. You can just okay the decision of the umpire, or if you want to give a comment, if required, it's up to you, the third umpires.
Okay.
However they choose, they can just go to the decision of the umpire. And we'll, Dr. Ashraful, we shall quickly introduce everyone so that.
Yeah, definitely. Thank you, Dr. Divakant. Dear ophthalmologists, welcome to this YOSI and BIOS Ophthalmic Debate 2020. So I would like to first introduce our third umpire. They will finalize the decision. I like to introduce the teacher of our teachers, Professor Abha Hussain. She is the president-elect of Asia Pacific Academy of Ophthalmology, advisor of Ophthalmological Society of Bangladesh, and most importantly, she is the chief patron of Bangladesh Young Ophthalmologists Society. We are grateful that Professor Muhammad Sharfuddin Ahmed is with us. He is the president of Ophthalmological Society of Bangladesh. He is the head of the Community Ophthalmology Department of Bangabandhu Sheikh Mujib Medical University. And most importantly, he is the patron of Bangladesh Young Ophthalmology Society. As umpire, we have with us Professor Muhammad Hazrat Ali. He is the ex-head of the Department of Ophthalmology of Burdam General Hospital and advisor of Bangladesh Young Ophthalmology Society. We have also with us Professor Muhammad Mizanur Rahman. He is the president of Bangladesh Glaucoma Society and president of ISM SICS Bangladesh chapter, and he is the advisor of Bangladesh Young Ophthalmologists Society. So, dear respected umpires, thank you for joining with us. Over to you, Divakant.
Right. Just a second.
Third umpire, Namita Sharma, you didn't mention her name.
Sir, Divakant will introduce.
Oh, yeah.
I'll have the honor of doing that. So let me have the honor of introducing Professor Namita Sharma. And she probably needs no introduction on this forum. She is the General Secretary of the All India Ophthalmic Society and leads various other ophthalmic organizations in India and abroad. And most importantly for us, she has been the pillar of support for YOSI. She has supported and not just supported us, she has pushed us to do more and do better always. And on a daily basis, she is a motivation for all of us. And welcome, ma'am. And then I would like to introduce our umpires. We have Dr. Vedang Shah. He is a vitreoretina consultant at Sri Netra Eye Foundation, Kolkata. And he heads the the West Bengal chapter of YOSI as well. And he is an executive member of the Young Ophthalmologist Society of India. Then we have Dr. Akshay Nair. He is a consultant. He works at various places in Mumbai and is already a very renowned oculoplasty surgeon there. And he is also the executive member of Young Ophthalmologist Society of India. Then we have Dr. Tushar Grover, who is the director and consultant of Vision Eye Center and a consultant at Sri Ganga Ram Hospital in Delhi. And he specializes in cataract, cornea, and refractive surgeries. And that's it. Dr. Ashraful, shall we go ahead with the toss?
Yes. So, is the screen visible?
Yeah.
Yes.
Yeah. So I can flip it, and Dr. Divakant will call. Okay. Shall we go?
Yes. So this toss will decide who. So the decision, whoever wins will have the decision whether they want to go first or second in their toss. So this will have a tactical advantage where if we go second, then you know what is in store and the person can decide their toss accordingly. So I'll go for heads, Dr. Ashraful. Please flip.
Okay, let's see. Oh, so
You-
it's tail. So, and
There is Dr. Ashraful in Bangladesh for the toss.
yes, sir. So we will go second.
Okay.
So I'll invite India team for batting first. Thank you.
Right. So the first, may I invite Dr. Avnish, and he'll be talking about, the topic is basically anti-VEGFs, whether anti-VEGFs will completely replace lasers in the future for treatment of diabetic eye disease. And you have 3 minutes. Please share your screen. In the meantime, I'll introduce Dr. Avnish. He is a consultant at IQ Super Speciality Eye Hospital in Gurgaon, and he takes care of various other regions in that region. And he is also the joint treasurer of the Young Ophthalmologists Society of India. Dr. Avnish, you have 3 minutes for your presentation. And I forgot to introduce one of our empires, Dr. Digvijay Singh, and he is the president of the Young Ophthalmologist Society of India, and he heads Noble Eye Hospital in Gurgaon and is working at various other centers in Gurgaon as well. So welcome.
Lokan, is my slides visible? Just give me a second. I'll just need to.
Yeah, they are visible. Just, I think you can play and go ahead. Yeah.
Are we good to go?
Yeah, please.
At the outset, I would like to thank both the Bangladesh Ophthalmic Society and our society, Ophthalmic Society, for this opportunity. And my topic is basically against whether the anti-VEGFs will, like the lasers, will still play a part in the management of diabetic eye disease. So good evening, all. Let's get with it. So the problems which we face in our countries is basically diabetes. What this is the global consensus where they say that the diabetes is at present 422 million, and that would be 629 by 2045. And in the diabetic eye disease is possibly the most common microvascular complication which we see. And because of diabetic eye disease, the visually impaired at present are 2.6 million, which will go to 3.2 million by the year 2020, which is like by finishing by this year. So, and what they have shown is like the concentration is basically in this low income and middle income countries like ours. So why lasers are still going to persist in the future? So I'll be talking in two aspects, that is diabetic macular edema and PDR. So for lasers in diabetic macular edema, what I want to just hold on us. Sorry. So why lasers and diabetic macular edema? Before the advent of anti-VEGFs, we had the laser as the more gold standard, but now whether they are currently obsolete or not, we have to see. So basically, the lasers they have this. When we give lasers, they cause thermal insult and they lead to death of photoreceptors and lead to decreased consumption, which leads to elevating the oxygen demand in the laser, resulting hypoxia. And they cause destruction of the RP and the outer retina, leading to another collateral damages, which we can see along with decrease in the macular edema. Now, with the advent of the newer lasers, we have these ultra short pulses of energies which are being given by these micro pulse lasers. And they have the selective retinal therapy where this is targeted to the RP. And these led to less collateral damages to the choriocapillaries and the inner retinal layers. So with the newer lasers, we have no visual burns, and we can actually give lasers to the subfoveal areas, juxtafoveal areas, and diffuse leaks can also be lasered. And there is less collateral damages with these. Now, coming to the treatment part, whether the convention, first we'll talk about the conventional lasers which we have had, and we have seen that with the ETDRS, there has been an improvement in vision as compared to patients who are not treated. And there was an off late in 2018, there was a review, which was a Cochrane review, which showed that there was an improvement in diabetic macular edema resolution following lasers if they had compared to the natural history of the patients. Secondly, coming to the DRCR.network research study, before the advent of before the protocol I, they had done this study and they had shown that almost 23% of the patients who had partial resolution of diabetic macular edema following lasers, instead of giving lasers, they actually observed these sort of patients, and even in these patients, almost 42% of the patients improved in vision and the DME decrease. So there is actually, when you give laser, there is no rush to repeat lasers, and there you may actually have improvement in vision. There was this study by Elio et al., which he said that what were the factors which actually led to improvement or worsening of visual acuity following lasers. So he during his in his study he has said that the vision which was present at the baseline had an effect other than these demographic factors, the OCT characters, fundoscopic findings, and other related factors did not have any influence over the outcomes of these lasers. Coming to the newer laser, that is a micropulse. This is a meta-analysis which compared basically micropulse with the conventional lasers. And at 12 months, they said that micropulse lasers were superior to the conventional lasers, even though there was no change in the resolution of the DME between the two groups. That was basically because of the decreased iatrogenic macular damage, the collaterals which we were getting with the conventional lasers. Coming to what sort of lasers we should actually have, that is the conventional laser, we had this one with a part or two part laser. The micropulse lasers have to be actually given with no spacing, and that may have better vision outcome. The micropulse have a downfall where the central macular thickness, if it is less than 400 microns, they have a better reduction in central macular thickness and visual gain. And none of the eyes required rescue treatment with bevacizumab in one of the studies. So micropulse lasers do have an effect, and the collaterals are less. And one thing is that if you're giving a patient with less macular edema will have better effects. So coming to macular edema, lasers plus anti-VEGFs in case of diabetic macular edema. So the comparison between the anti-VEGFs and the lasers one-on-one has shown that anti-VEGFs are better. But then again, if you follow the stricter protocols, that is around 4 to 6 injections over 6 months, like monthly injections are given. Even in those patients, almost 40% of the patients, they have persistent DME. As DME is not a sudden.
Can you just summarize?
Yeah. So just to conclude, in order to obtain best results, we need to give multiple injections. But what we see from the studies is like even these sort of patients, they tend to have more recurrences, or there is persistence of DME, and the laser therapy kind of helps in as an adjunct. And micropulse obtains better vision as compared to the conventional. Just one more last slide, which I just wanted to add, is like the patients which actually drop out in PDRs. If those sort of patients don't come back to us, they tend to have more worsened anatomic and functional outcomes. So I would like to say that if the lasers are still going to be there, at least in our part of the country, where we have to consider the cost of the injections and the follow-ups of the patients. And those sort of patients, if we are not treating them properly, they may actually have bad visual outcomes, poorer results, and persistence of DME. Thank you.
Thank you so much, Dr. Avnish. So very valid point that he has pointed out regarding the cost scenario in our part of the country. So let's see how Dr. Momin.
So now for the anti-VEGF part, I would like to invite Dr. Mominul Islam Badhan. Please share your screen. And meanwhile, I introduce Dr. Mominul Islam Badhan. Dr. Mominul Islam is the Assistant Professor of Vitreoretina of Islamia Isfahani Eye Institute and Hospital, and he is the Secretary of Bangladesh Young Ophthalmology Society. So, anti-VEGF, Dr. Momin. Dr. Momin, you are not audible. Dr. Momin, you are not audible. Please unmute yourself.
I think there's some issues with the audio there.
Hello.
Yeah.
Hello.
I think you need to put the microphone up closer to you.
Hello.
Yeah, we can hear you now.
Okay.
Please share the screen again.
Okay. Assalamu alaikum. I want to give thanks to Bangladesh Young Ophthalmic Society and Indian Young Ophthalmic Society to include me in this team, and I would due respect of all my umpires and captains, and I want to start my presentation. And Dr. Mohammadul Islam, I will tell about for the anti-VEGF will completely replace the laser in the future for diabetes retinopathy. We know that diabetes macular edema is a major cause of visual impairment in patients with diabetes disease. It can be defined as advanced complication of diabetes eye disease that involve the swelling of the macula causing the vision loss. Current management laser photocoagulation, pan-arterial photocoagulation, and anti-VEGF. And several studies investigate that efficacy and safety of the ranibizumab in treating the DME and compared to laser photocoagulation. In this resolve study, in this study that compared that 10.3 liters and 9.1 liters improve in ranibizumab and declined in 1.4 and 14.2 liters in SAM injection, and the central retinal thickness reduction in 194 in ranibizumab and 48.4 plus minus 153 in sham injection, and 10 liters improved, that is in 60% 0.8 in ranibizumab. And it was a multi-centered sham control study, a double mask study. That conclusion, ranibizumab is effective and improving best corrective visual acuity in well-tolerated DME. Future clinical trials required to compare the long-term efficacy. That is in a restore study, that is ranibizumab monotherapy and combined with laser versus laser monotherapy for diabetes macular edema. It was a 12-month randomized double mask multicenter study. It controlled phase 3 study. In this study showed that ranibizumab plus sham laser in 116 eyes and ranibizumab plus laser 180 eyes 18 eyes, and sham injection plus laser in 111 eyes, that the mean thickness, mean central retinal thickness was significantly reduced from baseline with ranibizumab minus 118.7 micrometer, ranibizumab and laser 118.3 micrometer, and laser is 16.1 point, only laser is 16.1.3 micrometer. So in this study, that conclusion was the ranibizumab monotherapy with combined with laser provides superior visual acuity gain over the standard laser in patient in visual impairment due to DME. In proliferative diabetes eye retinopathy, you know that the leading cause of blindness among the working age in adult in United States, 12,000 24,000 new cases in every year. Pan-retinal photocoagulation has been a standard treatment for patients with PDR since 1970, but there is a recent study in the diabetes retinopathy treatment of diabetes retinopathy clinical research network in protocol ACE that compared with intravitreal ranibizumab with pan-retinal photocoagulation treatment. That is, 2 years result of protocol is published in November 2015. Primary outcome was non-inferiority of vision comparison between PRP and ranibizumab. Secondary endpoints was visual field change, DME development, safety issues including need for vitrectomy, injection-related complications, and systemic adverse events. Result to were that eyes with PDR that plus 2.8 liter improve with ranibizumab and zero point 0.2 liters improve with PRP. Eyes with PDR with DME that 8 liters improve with ranibizumab and 2 liters improve in PRP. And vitrectomy required in 4% in ranibizumab, but 15% need in PRP. The field loss in with ranibizumab only 23 decibel and 422 decibel loss in PRP. That is, so DRC net intravitreal ranibizumab was inferior to PRP, was not inferior to PRP and PDR at 2 years. Ranibizumab provide better functional outcome with less need to vitrectomy and less frequent DME than PRP. That was the 5 years outcome, that is panretinal photocoagulation versus intravitreal ranibizumab. In this study, that is evaluate the efficacy of 0.5 milligram intravitreal ranibizumab and panretinal photocoagulation. In that, it shows that the ranibizumab group had over a lower rates the developing the visual impairment in diabetes macular edema, less visual loss. So in the, anti-VEGF will give less visual impairment and less field of vision loss in case of anti-VEGF. There is another study, that's protocol I for management of diabetes macular edema, that multi-center randomized clinical trial of 854 patients, that is 0.5 milligram intravitreal ranibizumab with given prompt or deferred, 4 milligram given in triamcinolone with prompt laser, and sham injection give with prompt laser for the treatment of central involving diabetes macular edema. That is
Can you please summarize?
okay. That in this study also there is one outcome, that intravitreal ranibizumab treatment provides the superior visual outcome compared to conventional laser treatment. In conclusion, I want to say that anti-VEGF have a proven track record in the management of DME and have been shown a better outcome in patient with PDR with DME. With better screening and earlier presentation, it is my belief that anti-VEGF will be the mainstay of treatment for the diabetes retinopathy for near future. Thank you. Thanks.
Thank you very much, Dr. Momin. And Dr. Divakant, over to you.
Sure. So Dr. Avnish, do you have anything to say before we go to the empires?
Yeah, one thing I just wanted to highlight was the 5-year results of the protocol S, which the doctor has mentioned. The dropouts in those patients was almost 34%. 66% of the patients actually followed up over a period of 5 years in a trial sort of a condition. So if you can just compare this in a real world scenario, so it's very difficult actually to have injections, monthly injections, and then to see. And as I showed in a paper which was published in 2008 after this protocol S, and they have clearly mentioned that if the patient is not on a follow-up, the results are more drastic as compared to patients who are only given lasers. So a patient who's having a PDR, it's better in our setup to give lasers, or maybe we can have a combination of the two rather than actually going in for lasers. And this is going to have a long-term effect in the future also. And as for the DME, I have actually put up my points. Thank you.
Thank you so much, Dr. Avnish. Do you want to give any response to that, Dr. Momin?
Thank you.
Okay. So next, let's go to our empire, Dr. Vedant Shah.
Thank you, Dr. Devakant. Wonderful presentations by both the teams. Both the batsmen have definitely put the ball out of the ground. One important thing that has to be noted is it is very personalized, and it is the patient care is very personalized from patient to patient depending on the stage of diabetic retinopathy. So that is one important thing that we need to understand. So if a patient is very early on, if the patient is probably in this mild to moderate kind of a diabetic retinopathy stage, the treatment is different. In the case of a PDR, the treatment is different. If the patient is having only DME, the treatment may alter. So this thing definitely we have to keep in mind. And as Dr. Avnish was mentioning, this new therapy of micropulse laser, it has never been compared. Whatever comparison that Dr. Mominul has been shown with in terms of the standard PRP laser that we are using. So micropulse laser definitely has a role to play, especially in diabetic macular edema. So that was, and also regarding the Proteus study, the Clarity study, which have compared the ranibizumab with PRP and also in combination, it has been proven that the combination therapy works much better as when compared individually. So from the part of the world that we are definitely taking into account the economics and the other factors, I still believe and I still continue to hold that position that PRP in cases of severe form of diabetic retinopathy probably would work better. If we have a patient in a probably mild to moderate kind of a diabetic retinopathy with a mild diabetic macular edema, if the hard exudates, so another one thing that we need to consider here. So in cases of hard exudates that are close to the fovea, giving anti-VEGF again can be disastrous. So keeping all that in mind, I think I would still go in for a PRP first before going in for a regular anti-VEGF injections. Economy, definitely number one, recurrent follow-ups. And again, over a period of time, as Dr. Avnish showed in his last slide, the anatomical and the visual outcomes or the functional outcomes of a patient who has been only on anti-VEGF and is lost to follow-up, and when comes back probably after a year odd, the visual outcomes are not very good. So that way PRP takes care better. Thank you.
So Dr. Vedant, you were saying that anti-VEGFs will probably not completely overtake this form of treatment, at least in our part of the world.
At this current point of time, it is definitely not going to take care. What I would rather not incline towards PRP completely, but I would rather say that the combination therapy and also at the stage at which the patient is identified with diabetic retinopathy matters a lot.
So what you're saying that so the India has won this innings? Are you suggesting that?
I think so.
Your final decision.
So let's
okay.
The third umpire.
Yeah. Let's have the decision from the third umpire.
So
very difficult.
So Professor Abha, madam.
Yes, very difficult, as because both have shown their own treatment in such a way that which way it's not biased, but I do want to say that anti-VEGF, it is of course acts very short time, and this is compliance is also a factor in real world, and the laser acts permanently, and it just reduces the production of VEGF and formation, which is a driving force of new vessel formation. So it may be the anti-VEGF may be the adjunctive of to laser, but it is not yet can replace the laser in real world. So I think it will be the laser, not only the anti-VEGF.
Okay, thank you, ma'am. So, ma'am also says that India has won this match. Now, Namita, ma'am, your comments or your decision?
I think PRP and intravitreal injections have to, complement each other, and each one of them is not exclusive of each other. It's not that you can just do in today's era just PRP or just anti-VEGFs. I think because both are going to deal with a different kind of, PRP is more for the laser that is done peripherally, and intravitreals are more, anti-VEGFs are more for the macular part. So I think they have to complement each other, and so that is why in my mind both of them are same.
Can I give a comment on it? As because all of them have told that one is complementary to another one, so both of them can win. As because of that, micropulse laser, when it will be given, what will be the cost? That should be mentioned, and that was not mentioned by him. So it may be a higher cost. So the cost will be then minimized. So in this regard, I think both of them has mentioned very nicely with the documents. So both of them can win. This is my comment.
Thank you, sir.
So I think we can declare that India has won the first innings.
Okay, so let's move to the second over, right?
Okay.
Yeah, so let's
yeah.
move to the second over. So after the first over, we are moving to the second over, that is the refractive surgery. So the case scenario is very interesting case scenario there. 23 years old female cricketer. So what we are playing now, 4 diopter stable myopia, topography, and what is your choice? Dr. Devakant, over to you. Can you please invite your speaker?
Sure. Dr. Gunjan, you're there?
Yes,
please,
I'm there.
please share your slides.
Yes.
And Dr. Gunjan is a very active and enthusiastic young ophthalmologist, and she did her diploma in ophthalmology with distinction from Venu Eye Institute in Delhi, and then she followed it up with a DNP and is presently pursuing a cornea and a cataract refractive surgery from Shroff Eye Charity High Hospital. And please share your slides.
Yeah.
So you have just 3 minutes. Please try to
Yes.
finish in the stipulated time.
Yeah. Good evening, everyone. And I'm very happy that I am given this chance to speak today. Happy birthday, Namita ma'am. It is a pleasure to join all the esteemed panelists today. So the topic I have been given today is femtosecond versus PRK in a -4 diopter spherical normal topography 23-year-old female cricketer. So I would say in the beginning only that I prefer quality that's more important than quantity, and one home run is much better than the 2 doubles. So why I say femtolasic? Femtolasic is a baitless procedure, it's painless, gives faster recovery, is safer and more accurate than the blade LASIK, and it is FDA approved. Moreover, we use disposables, and there is a very high chances of proper centration in this procedure. It is customizable and has predictable results. So how I say it is predictable, because we have reduced incidence of flap complications. Also, we can see that we can have the hinge here, and we have different diameters that can be customized, and also the energies and side cut angles can be modified. So I would definitely go for a femtosecond LASIK flap because it has a cleaner and vertical edge. Moreover, it's a planar flap, and we can see that it has a clear planar morphology as compared to the blade, and also there is very stable interface. So even thickness and vertical edges, they provide more stability and increase resistance to displacement or microstriae. There's also a homogeneous flap thickness, and there's a regular interface that is there in the femtolasic flap. Also, if you see the electron microscope view, the corneal bed surface comparison it was done, and in varying magnifications, we can see that the strobel interface that follows the flap creation with the femtosecond laser, it demonstrates a smoother stromal interface. So why not choose femtolasic over any other refractive procedure? US Air Force, Army, Navy, and Marine Corps, and US Coast Guard, they also have approved LASIK. Also, there was a report that was done, and they showed that the combat and the Army and the Air Force pilots that jumped from the parachutes, they had a stable flap even after the jumping. So they approved LASIK. Also, in 2007, NASA approved femtolasic also for the astronauts, and this was done after a rigorous study, which were done in different methods for creating the LASIK flap. And this study was done on a large number of aviators, Navy pilots, and all different studies that were done. They said that it was stable. So when I see this data, I would not be scared of doing this procedure in any of my patient, even though they have any chances of having any problems in later. Also, if I see the literature, then they say that femtosecond laser assisted LASIK yields better results than transepithelial PRK for correction of low to moderate grade myopia, and in a patient, she lies in the same category. So in this study, they said that femtolasic LASIK demonstrated better efficacy, safety, and predictability, and also had a faster visual recovery and less pain post-operatively, and there was no haze. Also, coming on to a large network meta-analysis that was published in American Journal of Ophthalmology, They did 48 RCTs, and this network showed that there were no statistically significant differences in both the visual outcomes, efficacy, safety, and visual quality. And also, femtolisic LASIK behaved better in predictability than any other types of surgery. Also, in efficacy, there was a SUCRA, that was a surface under cumulative ranking curve from best to worst. Femtolisic LASIK secured the best results. Also in predictability, this ranking, femtolisic LASIK secured the best results. If I think about the cricketer part, so I find this article which was published in the Indian Journal of Ophthalmology. Here I see that the ocular injuries that can be that was found in cricket ball while playing the cricket. The most common injuries were sphincter tear, RDs, vitreous hemorrhage, hyphema, Berlin's edema, etc. But I couldn't find any injury to the cornea. So
can you just conclude your talk?
So I would just say, why not the simple approach and choose femtolisic rather than going for complexities that have pain and then go for a steroid and then they have a further complication in future. Also, there are so many pain managements, but you can see that it is not completely right. There have been results that have been shown and objections being raised that the study that was done was not proven for the 9-hour post-operative results. Also the haze, if you see the haze after PRK, it's a very significant problem. So patients need to be given a better option. Also, in cases of high UV radiation levels, we know that there is an increased risk of post-operative haze. And in our patient, she is going to be there in the field and she'll have a higher UV exposure. So there are a lot of concerns also. If you use MMC for haze, you have a lot of increased endothelial cell loss and variability. Also, there's a small additive toxic effect on corneal nerves. Regression. So there are a lot of lower order abrasions also after this PRK. So I would like to choose this option rather than going for haze and pain. And at the end of the day, I will say the goals are simple, that is security and safety. Choose the right word, not the second cousin. Okay, thank you.
Thank you so much, Dr. Gunjan.
Thank you, Dr. Gunjan. So for the fourth adapter cricketer female, so I would like to invite Dr. Maziba Rahman Chaudhuri for her talk in favor of PRK. Dr. Maziba, please share your screen. Dr. Maziba Rahman Chaudhuri is the consultant refractive surgeon of Bangladesh Eye Hospital and Institute, and she is the scientific secretary of Bangladesh Young Ophthalmologist Society. Dr. Maziba. Please unmute yourself.
A very good evening to you all. Am I audible now?
Yes.
Respected umpires, today I will like to prove why I will choose PRK for my patient. Sorry, I'll have to start again. My video is not sharing, so I'll just take one moment. Yes, okay. Sorry for the trouble. I'll start again. So refractive surgery does not mean only one surgery, femtolasic. There's PRK, there's LASIK, there's SMILE, there's ICL. Now, why are there so many options? So that we can choose the correct surgery for each patient. And today I want to say that PRK, surface ablation, is the right choice for our patient. Why? Let's look at the patient profile. She is 23 years old with -4 stable refractive error and a perfect topography. So this patient is actually suitable for any form of refractive surgery. But why I have chosen PRK? Because of her profession. She is a cricket player and we have to keep that in mind. That means that she is at a risk of blunt trauma to the eye. The risk may be small, but I cannot risk that for my patient. So I have to think carefully, and that's why I have chosen PRK, because it's more safe. There is no flap related complications, as there are no flap, and I do not want an eye like this for her. Now let's look into some more evidence of why PRK. As my opponent was saying, that we need quality, but studies are showing that clinical outcome of PRK is equivalent to that of femtolasic in terms of predictability, in terms of refractive outcome, and in terms of visual acuity. So why not PRK? Also, our patient, she will be in the outdoors more. There is dust, she may be prone to more dry eyes. And obviously, we all know this, that dry eye is more common in LASIK than PRK. And most important is the corneal biomechanical properties. As there is no cut, studies all over are showing that yes, PRK is definitely superior than LASIK. There is than PRK. As each surgery, they do have some pros and some cons, but PRK is coming back in a big way in our refractive practice. Why is this? Because now we know how to control the pain and we know how to control the haze. For pain, what we are using is we are following this protocol that we are using topical NSAID through a soft BCL. What it does, it longers the analgesia time. So patients are more comfortable, and we are getting good result with this. And for the haze, there is nothing new to say, because we all know that with MMC 0.02%, the haze has gone down relatively. And for less refractive error, we don't use MMC. But for this patient, she has -4. So from 3 diopter onwards, we do use MMC for 10 seconds per diopter of refractive error. So I know that for this patient, I know I can control the pain, I know I can manage the haze. So I will give her the best choice, which is PRK. And lastly, I want to say, as there is a saying that one size fits all, but definitely it's not true, as we can see from the picture. So we need to customize. We need to customize our surgery. So definitely for better biomechanical stability, for better safety profile, and less chance of dry eye, there is no other option. It has to be PRK. Thank you.
Thank you, Dr. Maziba, for completing it in time. So, Dr. Gunjan, do you have any specific point on it?
So as already told, that the study that was done for PRK pain, that study has certain limitations, and I would just say that that protocol still holds a limitation. So I would disagree on that part, that pain is easily managed after using that BCL. Thank you.
Thank you, Dr. Maziba.
I think I have showed it in everything in the presentation, so it's fine.
So thank you. So we can go to our umpire. So Dr. Tushar Grover, sir.
I think I must say absolutely brilliant presentations by both of them. Both of them conveyed some very relevant points. So it'll be very difficult to declare a winner, but I will do that because as a personal preference, I do believe that for the pure reason that it's a sports person, my choice of surgery here would have been PRK, because yes, the incidence of flap dislocations, etc., would be much lower with femtosecond LASIK as well. But there are multiple case reports where you had a flap dislocation happening with blunt trauma, particularly if there's a tangential force that's been applied. So for me to be able to sleep well and for me to be able to feel safe, I would prefer that. Not that Dr. Gunjan would be in any way wrong in what she would do, but I think PRK is a safer procedure in this particular case. For somebody else with a -4 diopter myopia, my preferred surgery would definitely be a femtolasic. But in this particular case, principally because of the fact that it's a sports person, I would want to avoid femtolasic. So that's what my personal preference would be.
Thank you, sir. So we can go to our third umpire, Professor Ava, madam.
Excellent presentation, both of them. It's really difficult also, but still, as PRK, about PRK, it is really about the case is 23 years old, -4 diopter, and it is very stable. So, and also a cricketer. Very chance of having the blunt trauma. This is absolutely, everybody will agree. So I think this is not that much common as in femtolaser, as because dislocation of flap will be there. And I think that PRK is in this case, 23 years old women cricketer. For this, the PRK is the best, and she won.
Thank you, madam. Now, decision goes to Professor Namrata, madam, and her comment and decision will be learning for us. Professor Namrata, madam.
Thank you, Ashraful. I think both of them did great presentations. Gunjan really tried to defend femtosecond, very well by giving all the literature, all the studies, and supporting it with evidence. But I think the question was such that, it just goes to Masba because of the fact which Tushar has very beautifully brought out, and that is the fact that the person who's involved is a cricketer. And we know that even with the trivial trauma, the flaps, the femtosecond LASIK flaps or the microkeratome flaps can zip out even 15 years. There have been case report 15 years following LASIK. So that is something which we can't undo. And I think in this round, it is Bangladesh who wins.
Thank you, ma'am. Professor Sharfuddin Ahmed, sir.
I think the discussion was very lively and the decision was taken by Professor Namrata Sharma and Professor Abha Hussain with the comment of Tushar Grover. I think Bangladesh will win as because Mehejiba Chaudhary and Gunjan, both of them have given their strong points in favor of them. But in this particular case, I think Mehejiba Chaudhary, she won in this debate. Thank you.
Thank you. Thank you, sir. So the debate match is now going to be very interesting. 1-1, Bangladesh and India. Dr. Divakant, over to you.
Let's move on to our next topic. Dr. Karan, do you mind sharing your slides before? So we'll be talking about a businessman has come for cataract surgery, and what will you go for? So Dr. Karan has decided to go for FLACS. And let me introduce Dr. Karan. He is the Joint Secretary of the Young Ophthalmologists Society of India, and he heads the cornea services at the Sitapur Eye Hospital in Sitapur. And he is a very well-known young ophthalmologist in India. Please start your presentation, Dr. Karan. And 3 minutes.
Thank you, YOSI and Bangladesh Ophthalmic Society, your division, for the opportunity. So, as said, I'll just go forward a little bit. So in recent years, the phacoemulsification has changed the fundamental aim of cataract surgery, and where it was earlier the replacement of a cataractous lens by an IOL, now the UCVA is wanted by the patient to be the BCVA. So today's patient, what he wants is the vision to have a perfect vision. That meaning that the surgery should be not restorative, but in fact refractive. So coming to that, so the case scenario that we have a businessman wanting cataract surgery. Like a fellow, as you can see on the screen, a very rich person, one of the richest Indians and one of the richest persons in the world, Mr. Mukesh Ambani comes to your clinic, and what are you going to do? So he's going to ask you like, what is the best available? And then you're going to say phaco, and he's like, are you sure? Why not laser? Why not robotic? And he's going to say, he would have, already gone through Google and said, there are so many problems with the incision, capsule rhexis, phaco effects, and the astigmatism, so many parts. Why aren't you going for the robotic stuff, which is better? So as we said, incision has problems, capsule rhexis can have its effects, phaco can have its problems, particularly with hard cataracts, and you have to control astigmatism as well. So femtosecond laser is the way to go because of its precision and reproducibility. So femtosecond laser produces 3D corneal cuts, which are reproducible, multiplanar, which are self-seaming, and they give great architectural stability, and therefore the complications like leakage are much, much reduced. So if you look at this, you can make even the cuts or the incisions can be made customized when you're using femtosecond laser. So what you can do is the laser also allows a contour gated capsulotomy, and you can choose according to the pupil or the limbus, or the different protocols are there, and you can choose accordingly. So because of this, the capsulotomy is very precise, and this gives the stability of the IL because of a consistent effective lens position, and which gives refractive credibility and minimizes the risk of PCO formation. And as a result of it, because whenever, and also when the fibrosis takes place, it's a more symmetrical and uniform fibrosis, and therefore this is the choice you would go for, a spheric IL, a toric IL, or even a multifocal IL. So as I said, if ELP is particularly important in such cases, and a better ELP leads to better results. If you compare the capsulotomy of a femto, as you can see on this side of the screen, it's perfectly round and beautiful, whereas a little bit, it's much more different in a manual one. And this is the cadaveric eye when it's been taken. You can see the starking differences that are there between the two capsulotomies that have been done. So this one patient had a right eye multifocal IL, which was non-femto surgery, and the left eye had a multifocal surgery with the femto laser platform, and you can see the difference and how uniform and how great the fibrosis is also there. So it also helps in nucleus management, and because of this, there are a lot of modes available. So you can segment, you can soften the nucleus, and thereby reducing the ultrasound energy that you would do in case of phaco. Sculpting is skipped, multiple custom patterns are available, and faster and easier chopping. And this makes it easier as well. And particularly for hard cataract, it gives a better chance for the endothelium, and so therefore there's less damage to that, even to the anterior lens capsule. As a result of all of this, it makes lesser post-operative edema. 4 out of 10 cataract surgeries actually in astigmatism management, and because of the fact that the femto gives a platform of LRIs as well, so you can treat up to 1.5 diopters of astigmatism. If you're not comfortable with the toric in that part, you can use femto LRIs, and it's a pretty easy step, and it's just takes about a couple of seconds, and it's done. So
can you conclude?
Yeah, summing it up, special cases are there. So in special cases like a mature cataract, if you're dealing with something like this, the rhexis can run away, and if it's an intumescent lens on the other side, you can see there's an Argentinian flag. So these kind of situations can be avoided, as you can see in the picture, with the use of a femto laser. And even in weak zone use, there's less stress, and so therefore you can center the capsulotomy on the lens and not the pupil. So basically, you have two choices to do, whether you want to evolve or you want to repeat. You want to go for an older MacBook, or you want to go older Apple laptop, or you want to go for the latest MacBook. That's your choice. So as Charles Darwin had said, only the fittest will survive. Thank you so much.
Thank you, Dr. Karan. So now I would like to invite Dr. Ashfaq Rahman Khan. Dr. Ashfaq, please share your screen. Meanwhile, Dr. Ashfaq is the consultant of Al Noor Eye Hospital and Bangladesh Eye Care Hospital.
Am I visible?
Yes. You're audible too.
Assalamu alaikum and good evening to our respected judges, panelists, fellow speakers. I am Dr. Ashfaq Rahman Khan, consultant phaco surgeon, Bangladesh Eye Care Hospital. As you know, phaco is the gold standard procedure which incorporates between the surgeon's skill and technique and advanced technology. If a surgeon's skills are good as world's #1 all-rounder, Saqib Al Hasan, then we don't need to depend on an expensive hybrid procedure called flex. Now, flex, expensive procedure, is it worth it? I will leave that verdict to our honorable judges. My fellow speaker, young talented surgeon, Dr. Karan Bhatia already highlighted the flex. I will not go through that. Flex is basically a femto-laser based procedure which helps us in incision making, capsulotomy, and nuclear fragmentation. So the big questions arises about choosing between the surgeon's skill, technique, and strength versus a posh hype like flex. Now, let me go through some videos where you can understand it. For me, as a phaco surgeon, I always prefer a good rhexis Rexis is always facing a googly delivery. You have to play it according to its merit. But with our skill, we can achieve a standard optimum size Rexis for the premium IOLs, and is more like the flex equivalent. Now, on the other hand, in case of the white intumescent cataract, I always prefer to go for the double Rexis, which is safe. And here, in other cases where I am using the iris hook, the Rexis can be done. In this particular case, you cannot afford the flex to do the surgery for you. Only the human hands and skilled hands can do the surgery for you. Now, let's go to the nuclear management. Nuclear management, an important step. I always prefer the adequate scalp with a good chop. A good chop can help you neutralize the zonular pressure, as well as depending on the grade of the cataract, you can easily manage it without the help of an expensive procedure called flex. Now, in case of white intumescent Morgagnian grade, also if you have a good control over the chop, then you can easily complete it. And in this particular case, which is a mid-dilated pupil where the flex fails, you can still manage it with your surgical skill with conventional phaco. Now, flex has some limitation like small pupils, already I told, corneal skull and filtration blebs. After analyzing the studies, journals, and everything, we can highlight that flex system has difficulty in making clear corneal incision, incomplete incision due to docking failure in the docking technology. A laser capsular access may not always be complete, incomplete capsular tag there. Flex can trigger intraoperative meiosis. That will difficult for the surgeon to engulf the nucleus. Also, it takes significant longer time than manual cataract procedure, and a big financial investment, which is a burden for the patient. Now, several studies that have already shown that both these studies shows that there is a similar refractive and visual outcome in between the phacoemulsification and the flex. So also researchers found that evidence to support claims that flex is not superior to conventional phaco. In fact, postoperative complications were lower with the conventional surgery. Some surgeons also stated that flex is more time consuming, cost doubles, and a financial burden for the patient. Now, my honorable judges, the journey of the cataract surgery evolved from the couching to ICC, then ECC, SICS, and we are doing phaco now. The evolution has only one aim: to ensure the best vision for our patients. Nowadays, we are more focusing on a refractive-based phaco surgery. So why spend more on a time-consuming, higher learning curve, highly expensive procedure with no benefits over visual outcome or refraction? Let's instead, we can encourage the patients to go for the premium IOLs, which will have the impact on their visual outcome rather than luxurious, expensive procedure like flex. Thank you all for this wonderful session.
Thank you so much, Dr. Ashfaq. So, Dr. Karan, your counter to that.
Very excellent talk given by my counterpart over there. He's highlighted all the points very well. But I would say in special situations like harder cataracts, when it does a little bit of softening, and the subluxated lenses, it does have a big advantage. That's it from my end.
Dr. Ashfaq?
Yes, I will add something that if Mukesh Ambani wants surgery and the pupil is lesser in diameter, why do you risk for the flex? Go for the basic surgical skill. Ultimately, in the end of the day, he will not argue with the robotics or the laser system. He will argue with you. Why taking chance with this kind of person, and give him the refractive IOLs, premium IOLs that will ensure his visual outcome will be good. Thank you.
So now we would like to move to our umpire, Professor Muhammad Hazrat Ali, sir.
Thank you very much. Can you hear me clearly?
Yes, sir.
Yes, sir.
Okay, both have a excellent batting, and both have crossed their ball over the boundaries. This patient, he is a rich man, he has come for surgery. So why we should not offer him the most advanced surgical technique for this patient? Though this may not be applicable to other patients, but for him, I think this is the best option for these patients, as long-term complications are less in respect to endothelial problems, and there is perfectness of the surgeries and IOL implantations. And most of these patients to nowadays, they come with the internet knowledge. They knows about the surgeries, which one is better, and they will come with that knowledge and they will ask for that. Unless you can perform that, he will not do the surgery by you. The problem for the young ophthalmologist is that a person so rich, like Advani you told, he will not come to you for surgery. Even if you can perform this flex, he will come to me, a senior surgeon. But I am the senior most surgeon here, most likely after Professor Abha Hussain. But there is some tremor in my hand. Okay, he will come to me. This Advani will come to me for surgery. But this flex is a blessing for me, because during capsulolysis, there will be no tremor. The machine will do this. It will break the nucleus. It will develop the nucleus. So this is a blessing for the senior surgeons. And at last, I'll say that Dr. Karan Bhatia, he has done better, because the choice for this moment, for these days, is the latest technology. And unless you master it, the next stage is coming, that the 3D cataract surgery. And after that, there is coming robotic cataract surgery. So you have to prepare, this young ophthalmologists have to prepare for this. That is starting with this flex. Thank you very much.
Thank you so much, sir. Very valid points. And Professor Ava, ma'am, your comments.
I think this time, first, Professor Shafuddin, as because he is always third umpire, third umpire, not the third person.
Okay, madam. Thank you very much for giving me scope to say something. In this regard, Professor Hajrat Ali has told that both of them has much more boundaries, and some of the points are like that. They have made 6. So here I will say that if the patient want to buy the service, we are to sell it according to his desire. If he is very much rich, or he is wanting that he will be able to take the flex, no problem, no cost, no time consuming, so you can use it. But the points given by both of them are very strong one, Karan Bhatia and Ashik. I thank all of them. But in this patients, if you say that whether phaco or flux, patient choice is the main. The points given by Karan Bhatia, I think Karan Bhatia own this batting in this points of discussion. Thank you.
Namrata.
I think femtosecond cataract versus manual phaco is going to be a debate and has always been there. But I think a person who can afford the surgery, a person who's motivated to get the surgery, and if the surgeon knows the machine and surgeon knows how to do it, then flex is the way to go. Because if the person is motivated and can afford, and if you do a conventional phacoemulsification, he's not going to be happy about it, even if he gets 6/6 or N6, because he's going to say, I could have done better had I done a surgery which was more expensive, and technology as per the Google, which was, had more far-reaching effects. Now, for a person who cannot afford, you would probably say as a surgeon that it really doesn't matter. The clinically results are, both of them are same, and you don't worry. You will get same results as what you would, when you do femto. And surgeon, of course, is going to be good whether you do flax or you do. A person who can do good conventional will be a good flax surgeon, and vice versa, because flax is a procedure which has come much later on. So I think in this, because Divakant or Ashfal have put a very tricky question, they've qualified it as businessman. So the moment you say businessman can afford it, is motivated, so just go ahead with the flax. The question comes when the person is not able to afford it. In that case, then you try to convince from your own side, don't worry. It doesn't matter. The results are same. Whether I do it or the machine does it, I do better than the machine. So, I think it is as per the patient's affordability. So in this case, I think Karan Bhatia will, win the match. Although Afshak did present beautiful videos on complex scenarios.
Thank you. So, Ava madam.
Yes, both the player, Ashfaq and Karan Bhatia, played so nicely. Everybody said that. But here is a point, businessman. What type of businessman? They didn't mention it, Ashraf and Divakant, simple businessman. Whether that businessman can afford flax, that should be encountered as, because simple selling the vegetable in the roadside is also a businessman. Whether we will go for flax for him, as because what will you choose? It is my choose. It is the surgeon choose, and surgeon is always giving that expensive surgery, whether he can do or not, as because he is a businessman. All businessmen are not that much rich person, then everybody will be the top level. So I'm very much confused that both have played so nicely and have their point elaborately discussed, and everybody said that both have over boundary, also 6. So I'm really thinking that whether it will go for flex or it will be in FACO. My decision will be it goes as businessman, what he needs, vision. It both have given this vision. We know that. But still patient wants that everybody has searched the internet and which one is better, they can tell. But there are some businessmen, they didn't know what is FACO, what is small incision cataract surgery, what is flex, and what is the robotic surgery. So in that case, they are asking us, what your decision? In that case, I will go for normal FACO, not the flex. This is my decision, and Dr. Ashfaq on the game.
Thank you, ma'am. Thank you, ma'am. But the decision comes that India has owned, because
Right.
the bouncer of the Ashfaq Karan made it over boundary. So now
Yes.
it's 2 versus 1, India 2, Bangladesh 1.
Yes.
And now we are moving to our next over. It's on glaucoma. So the topic was POSG management, early surgery versus medical management. Dr. Divakant.
Yeah, so we have a wild card entry here. Dr. Manak was supposed to present, but he had some emergency and he could not come. We must thank Dr. Divya for stepping in at the last moment. So she has, Dr. Divya, just share your slides and I'll introduce you in the meantime. So she has been educated from the most prestigious institutes like the Armed Force Medical College, Pune, and GNEC in the MAMC at New Delhi. And she has done her senior residency in glaucoma and strabismus. She has presented her work at various international meetings and has won best paper at APO and many other awards as well. Please, Dr. Divya, start your presentation.
A very good evening to all esteemed faculty and dear colleagues. So management of POAG, especially in developing country like ours, I feel early trabeculectomy is a better option than medical management. When faced with a glaucoma patient, we always wonder whether to give medicines or when to take first surgery. But we need to understand that management of glaucoma is not a one-shop stop, just like cataract. There is a progression. So we need to see that patients who are diagnosed early and those with a rapid rate of progression are different and they need intensive management. So whether is it to be medical management or trabeculectomy. So drugs have been around for about more than 100 years now, but they have their own pitfalls like systemic side effects and non-adherence due to various reasons. Trabeculectomy is the gold standard surgical option for reducing IOP in these patients. They allay the fear of blindness and enhance the quality of life, which is very important as this is a chronic disorder. It leads to less dependence on drops and clinical follow-up and diagnostic tests are reduced. The best candidates for a filtering surgeries are those who are intolerant to medications or poorly adherent. Another benefit is reduction in the IOP elevation with postural changes. Trabeculectomy in itself has undergone a lot of evolution, wound modulation with antimetabolites and ologen. We have releasable sutures, laser suturelysis, and post-operative management like torpedo bandage and needling, which has improved the outcomes. As early as 1988, this question was asked, and they compared patients on AGM and those post-trav, and found that those patients on AGM, about 32% required trabeculectomy, whereas only 15% of trabeculectomy patients required an additional AGM. The collaborative initial glaucoma treatment study compared patients with high IOP and visual field loss and divided them into medical regimen and trabeculectomy. They found IOP reduction was better in the short, medium, and long term, and also the advanced field loss. They progressed slower with initial trab rather than medical management, and the fluctuations caused, especially in the AGM group, caused visual field progression. However, the caveat is that diabetics and African Americans did worse with initial surgery. So this is not a one-size-fits-all formula. We need to see which patient needs trab and with medical management. Patients which have severe functional impairment, younger patients, need to undergo surgery earlier, and those which are low risk group, like OHT and elderly with mild visual field damage, can be monitored on medicines. But the management of OAG, we have to stop the eye from going blind. So if you give medicines to a patient, sometimes it leads to a sense of complacency that they feel just like diabetes, my glaucoma can be cured with medicines, which is not true. So in the long term of glaucoma management, you need to see the profile of the patient, whether they can afford the drugs, whether they can put the drops, and how they are progressing. So early treatment, that is not the first line, but early treatment with trabeculectomy definitely helps these patients. So the take-home message is advanced glaucoma at presentation, failure of medical therapy, poor compliance or intolerance to medical therapy, those patients having JOAG or Axenfeld, and secondary glaucoma. All these patients need an early trabeculectomy rather than medicines. So we are celebrating 50 years of trabeculectomy, and this has stood the test of time. Thank you.
Thank you, Dr. Divya. Now I would like to invite Dr. Bipul Kumar Sharkar for his debate on medical management. Dr. Bipul, please share your screen. And Dr. Bipul Kumar Sharkar, he is the Assistant Professor of Isfahani Islami Eye Institute and Hospital, and he is the General Secretary of Bangladesh Young Ophthalmologists Society.
Thank you all. I, Dr. Bipul Kumar Sharkar. I'll talk in favor of medical treatment in primary open-angle glaucoma. Before going to medical treatment, I would like to share few of my cases of trabeculectomy. A 35 years lady, I did the uneventful trabeculectomy, but after 6 months, I found there is a flat blade. Another cases, 41 years, after uneventful trabeculectomy, I also found there was also vascularized flat blade. In both of cases, I used antimetabolites, mitomycin C in appropriate dose in appropriate technique. But after few months, I found blade is not functioning and surgery not acting properly. Another case is 51 years, just after 3 years, I found there is a thin 60 blade. Another case, 62 years, up to 5 years, everything was good. But after 5 years, I found there is a large, thin hanging bed. So what we found, after using proper antimetabolites or all other technique, after few times, blade not acting and surgery not act properly. Another cases, I did all step in adequate technique, but after few weeks, I found there is a huge choroidal detachment. So what we found, that after taking all precaution, all measure and proper use of antimetabolites, anything can happen in trabeculectomy. So trabeculectomy is not a surgery that you make a ostium or make a hole. So be careful. Anything may comes out from the hole. So decision is yours. Why you do early trabeculectomy? So you should, choice is yours. You should take the right decision, and how will take the decision? You should follow the guidelines. I will show few guidelines what they said regarding how you choose the proper treatment for primary angle open angle glaucoma. The most acceptable guideline is ICO guideline, and they described when in early stage of glaucoma, treatment option is medication and laser trabeculoplasty. And in stage of glaucoma, treatment option is medication, cyclophotocoagulation, and others. And only in advanced type of and moderate type of glaucoma, treatment option is medication, laser trabeculoplasty, and then trabeculectomy. So what we found, in case of early and in stage of glaucoma, there is no option of trabeculectomy. In case of advanced and moderate glaucoma, you can do trabeculectomy when your medication or laser trabeculoplasty failed. So there is no option of early trabeculectomy. Another guideline, in European guideline, they also suggested that your primary treatment should be medical therapy. When it failed, you go for laser trabeculoplasty, and then you can go for surgery. And they also describe how you choose your first treatment, and they describe that it should be drug and how you choose the drug. Your first choice should be monotherapy. You can try PG analog, beta blocker. If target pressure not achieved, you can add second drug. If target pressure not achieved, then you can go for other therapeutic option like surgery or laser. So there is no option of early trabeculectomy. Another most acceptable guideline is preferred practice pattern by American Academy of Ophthalmology. They also suggested medical option is your first treatment, then go for laser trabeculectomy, then incisional glaucoma surgery. So actually, I am a surgeon. I love to do surgery. I am not against of trabeculectomy, but you should follow the guideline. What guideline said? In case of, though there is a huge complication of trabeculectomy, and you should follow the guideline, and you first try with medical treatment. If target pressure not achieved, then go. You can add laser. If not achieved, then you can go for trabeculectomy. So I would like to say you should always follow the rules, obey the guidelines. If you don't obey the rules, you may lose your patient time. Thank you. Thank you so much.
Dr. Ashraful, please unmute yourself.
Thank you, Dr. Bipul. Am I audible?
Yes, yes.
Yes, thank you. So the thing is that
Yes.
for the early treb and the medical therapy, the follow-up and the patient awareness is also a very important thing. So Dr. Divya, do you have any counterpoints?
Yes, regarding the complication of trabeculectomy, as mentioned, like complications like choroidal detachment, they can be easily managed with steroids. And needling has to be sometimes done 2 to 3 times to get the adequate results. And we have unpublished data that even 5 years old bleb when needled have good results. And sometimes you can do an internal revision of the bleb in case the sclerostomy is scarred. So that gives a very good outcome. And in case of an overhanging bleb, we have done a double AMG and have very good outcomes. And regarding, there are obviously many guidelines, but how many of those guidelines have been formed in India on Indian patients? Like all these are European and American guidelines. And they have specific guidelines, say for African Americans, because they form a vast ethnicity of their groups. But none of them have actually studied Indian eyes. If you see our glaucoma clinic, almost 80% patients will present with an optic disc change or a visual field change. So according to the guidelines, they do not fall in the mild criteria. Most of our patients will be in the moderate to severe category, and those do require an early trabeculectomy. And machines like ALT, AS are not available I assume in 99% of our clinics. So those procedures anyway cannot be done. So for management of patients that we do see, I feel that trabeculectomy, early trabeculectomy, obviously it's not the first thing, but an early trabeculectomy helps them to save their vision.
Thank you. Thank you. So Dr. Bipul, any counterpoints?
Already my opponent accepted that trabeculectomy has huge complication. So I would like to say journal is not a acceptable things. Anything can publish in journal. So guideline is made after reading the all journal, and expert will sit to they make the guideline. And our topics was POAG management. It not early stage, moderate stage, or advanced stage. So our management option was POAG. We know in case of POAG still now in world definitive treatment, first line treatment is medical treatment. If target eye should be not acid, you can go for trabeculectomy, not trabeculectomy in early stage. Thank you.
Thank you. It was a very good overall debate. Let's directly go to the umpire, Professor Mizanur Rahman, sir.
Thank you, Dr. Ashraf. Now, first of all, I must thank BIOS and YOSI to organize such a mass and team between Bangladesh versus India for debate for such nice topics in ophthalmology. It's a very good webinar, and this is a very new thing. So regarding that topics, glaucoma, basically it's a very unpredictable for diagnosis and for treatment. And both the team, both the players, how finely they have presented their topics. Actually, I have nothing to say. Comment is very difficult here. But few things as umpire I must mention. Regarding the treatment of POAG, we must consider some baseline evaluation, family history, the optic disc evaluation, the visual field, and the level of the IOP. And considering all these things, initially we start the medical treatment by one drug, and if it is not controlled, then second drug, and if the progression is not controlled, then we can do laser. And finally, we think about the trabeculectomy. Trabeculectomy, definitely it's a gold standard surgery for the glaucoma, but the post of filtration performance and the post of serious complications, it's a matter of concern. That's why we first think about the drugs, and we continue with the drugs, and we follow up the patient. If the target IOP is maintained and if the progression is stable, in that case, we should continue with the drugs. Otherwise, if it is progresses, and if the field sense or the optic nerve sense of the target IOP is not maintained, then we should do the trabeculectomy. That is the opinion regarding these topics on behalf of me. Thank you very much.
Thank you, sir. So let's move the comment from the third umpire, Professor Mohammad Sharfuddin, sir.
Thank you. We have heard, we have seen the battings of both the players, Dr. Bipul and Dr. Debia. I think the batting was very good. There were, the points were very near. But one thing we can mention that the patient's complaints and the, one of my teacher told me during my study that if a patient comes to you who cannot have this capacity for compliance and much more money, he has come to you with selling his land. So make the trabeculectomy, as because he will not be able to continue these drugs for whole life. So this is one thing. Another thing is that earlier we can try with the drugs. If we use the drugs and if there is no progression, then we can use the drugs. But when the patient will come to you with the cup-disc ratio is increased and there is the raised pressure, then we can go for trabeculectomy. So in this batting, I think Bipul has given much more points. So Bipul will own this batting.
Thank you, sir. Thank you, sir. Professor Namrata, madam. Madam, your decision is pending.
Mine?
Will it be medical treatment or early trap for POAG management?
I think Dr. Rahman has very beautifully summarized the whole situation. I mean, whatever you may say, you will not go for a primary trap. You would first try medications and then do trap. So I think I think Dr. Bipul Sarkar, it goes to Dr. Bipul Sarkar.
Thank you, ma'am.
I think his strategy was very smart. It was like a reverse psychology kind of a thing. So first he started with complications of trap, and then it was a very clever way of. That's another way of doing a debate. In a very clever way of doing it.
Yes, he made his opponent weak first of all.
Thank you, madam. Professor Abhausan, madam.
Yes,
Professor
Dr. Dibba and yes, I am. Dr. Dibba and Dr. Pool both has done their batting excellent, and point is just very close each other. And what the umpire has said, that is also rightly said, that this is the open angle glaucoma, and everybody we know that open angle glaucoma is such a condition where medical treatment can take all along the entire life if the optic discs the cupping is not there, the intraocular pressure is not rises, and also the field is okay, and the compliance is not there. So this is, of course, we deal all this thing, and surgery always have some complication, more or less. That is, of course, we know that. And when we are in earlier time, I always said that in 1981, 82, at that time, I have started my ophthalmology career. At that time, I have seen my boss, my teacher, my mentor, Professor A.Q.S. Harun, doing trabeculectomy with a very skilled hand, with a very cautiously, but still, what people said that still then there are some complication. There is the cataract formation and also the other bleb failed and all these things. So why we will go for early trap, as there are so many things, and for you put your explanation is very nicely for secondary glaucoma, for other condition. It's okay. Of course, you will do trabeculectomy. It's not nobody will ask why you are doing. But for open angle glaucoma, I think Bipul has shown it nicely, and both Dibba has her point is also very valid in her condition. So still Bipul is higher, and I'll go in favor of Bangladesh, and Bipul own the game. Thank you.
Thank you, ma'am. Thank you, ma'am. So after 4 over, it's tight till now. So Divakant, over to you.
Thank you. Let's hope we do have a decision at the end. So let's move on to the next topic from oculoplasty. May I invite Dr. Puneet Jain? Can you please share your slides?
Yeah, please. Am I audible?
Yeah, you're audible. Yeah. So Dr. Puneet is currently working as an oculoplasty, oncology, and facial aesthetics consultant at IQ Super Specialty Eye Hospital in the Delhi and the NCR region. And he has been trained from the best, the Maulana Azad Medical College and the All India Institute of Medical Sciences. Then he followed it up with a fellowship at Center for Sight under Dr. Santosh Honavar, and then as a fellow at New York Eye Cancer Center in the US.
Are my slides visible?
Not yet, not yet.
Not yet, okay. Just give me 1 second. Okay. How about now?
Perfect. So you have 3 minutes.
All right. Okay. Thank you, Dr. Divakant, for that elaborate introduction. You expanded 2 lines into a paragraph. I really appreciate that. And thank you for putting faith in including me in your playing 11 tonight. So I hope I can do justice to my spot. In real life, I am an opening batsman and a bowler. So I'm coming second or third down. I don't mind. So the topic that has been given to me is eye drops for OSSN. No, so let's talk a bit about that. Now, the burning question with every patient that comes to any of our OPD, irrespective of the specialities, can you treat everything with eye drops? So this is not OSSN, this is just cataract, an advanced cataract. So we started out in 67 with Dr. Kelman starting phaco, and the answer still in 2020, we are finishing 2020, is no. Now consider this scenario. If any of these patients was to walk in your clinic or your OPD and ask the same question, then your answer in today's day and age would be a solid yes. So topical eye drops, so topical chemotherapy or immunotherapy has been used as adjuvant or adjunctive therapy post-surgery since many decades now. But this debate and this presentation focuses on their use as primary therapy as a replacement or over surgery. So for this, we have immunotherapy in the form of interferon eye drops or chemotherapy in the form of 5-fluorouracil or mitomycin C, what we call commonly now as magic potions to the ocular oncologists. So why at all use eye drops? Non-invasive. So I'm just going to use those keywords which the patients Google these days or are aware of and are looking for. Blade-free, laser, non-invasive. It treats the entire ocular surface. So it even treats the subclinical areas, the areas of dysplasia, which obviously will not be overt on clinical examination. It has no risks of surgery. Most importantly, corneal scarring in case of corneal OSSN, limbal stem cell deficiency, and symblepharon formation. This eventually leads to a better cosmetic result for the patient. The result is also very predictable as it is not dependent on the surgical technique or the surgeon or the setup or the specialist who's treating, how much experience the specialist has. It's a certain protocol that needs to be followed by the book, and that's about it. It's a small setup treatment, so can be dispensed even out of a small clinic. You don't need a fancy OT, you don't need a cryo machine, you don't need anything. It's pretty economical, so much so that the entire interferon course of 3 months would cost a patient only 4,000 to 5,000 rupees if we are talking about the Indian subcontinent. Now, till now, all the talks that we have heard, there has always been there has been a split between what is latest and what is economical. I am presenting to you something that is latest as well as economical. So I hope my opponent will have a tough time defending this one. Now, and you know, there are so many patients who are not willing to undergo the knife or are not fit for surgery because of comorbidities. They are also very good candidates for topical chemotherapy. Now, all this eventually culminates into a happy patient, and happy patient is always a compliant patient. This comes with a patient rider. Nothing in medicine is 100%. Any patient with intraocular or scleroinvasive OSSN is not a candidate for topical chemotherapy. So starting with interferon alpha, it is the most commonly used now, especially in the Indian subcontinent, probably because of the low cost and economy. The dosing is 4 times per day for a period of 3 months. The duration is determined by the response, and it needs to be reconstituted, which we will see in the subsequent slide. A lot of literature now on these on the use of interferon, and the efficacy is in excess of 90%. Now, even surgery is not 100%, and the literature reports that even with margin negative histopathology, up to 37% patients have recurrence. So don't focus on 100%, focus on 90% versus 33% recurrence in surgery. The adverse effect profile is very favorable, and only transient flu-like symptoms are seen. Cold chain needs to be maintained, and the reconstituted eye drops needs to be refrigerated. Now, the ultimate aim is to reconstitute it, to dispense it in 1 million international units per ml. You need to label the drop and make sure that the patient maintains the cold chain. So my exposure to topical chemotherapy started during my fellowship days at New York Eye Cancer Center, where I had the opportunity to actually see these patients firsthand being treated and responding so well. So this patient you would never think of treating with eye drops, is such extensive lesion, but this is how the patient looks at 1 year follow-up. The patient received the treatment as per protocol for 3 months and has been tumor-free. Now there is stark absence of any symblepharon, any scarring, any corneal scarring, or any limbal stem cell deficiency, which would have been the case however nicely the surgery would have been done. A similar case with predominantly corneal OSSN. The patient is absolutely tumor-free, and you can see a beautiful clear cornea to everyone's delight. Another patient with a smaller OSSN, this gentleman was an auto rickshaw driver, presented to me 7 months back in the OPD, was being treated elsewhere for nodular episcleritis. The patient received 3-month interferon therapy, was very happy because the treatment was very cheap. And this is how he is at 6 months, doing very well and with complete resolution of the tumor. 5-fluorouracil is also used, but more so in the United States and UK, because interferon is very expensive there and all patients cannot afford it. I know it might sound surprising, but yes, it is that expensive that even the those patients with the high standard of living cannot afford it. So 5-fluorouracil is usually the second choice. Most of the literature is from the Bascom Palmer Institute, Carol Karp and group, who have done extensive work with use of 5-fluorouracil. The theoretical advantages include less frequent dosing because it needs to be given only for 2 weeks, is more economical, and there is no need to maintain any cold chain here. Mitomycin C has gone out of vogue because of the unfavorable side effect profile, is no longer preferred for primary chemotherapy in OSSN.
Dr. Puneet,
this is one of the just concluding last couple of slides. So this is the landmark article which came out from the New York Eye Cancer Center, where they treated even giant OSSN with topical chemotherapy with 100% efficacy. This is the work by the Carol Karp group, who they have worked extensively on use of 5-fluorouracil. Even here, you see a good sample size and more than 82% resolution of tumor with minimal side effects. Adler et al., just to summarize, Adler et al. Did a comparative study in change in standard of care for OSSN over the decade 2003 to 2012. And they found out that there has been 5 to 10-fold increase in use of interferon therapy as monotherapy. So this is not something that a part of a particular country or a particular group is doing. It is being followed globally now over the past decade, and we are now in 2020, and it is more and more being used now. So to summarize, there's nothing to lose. If at all the patient doesn't respond fully, you achieve chemo reduction 1, and you also treat the entire ocular surface for any subclinical dysplasia or subclinical disease, which is not evident on clinical examination. You can treat small and giant OSSN alike. There is no limitation with respect to size. You can start with single therapy and switch to 5FU if there is inadequate response, and the duration is governed by the response of treatment, usually taken random cutoff of 3 months. So that begs the question, why at all use the scalpel when you can deal with drops? And as the famous quote goes, that progress lies not in enhancing what it is, but in advancing what will be. Thank you so much.
Thank you, Dr. Puneet. And for now, in favor of surgery, I would like to invite Dr. Sharmin Ahmed. Dr. Sharmin, please share your screen. Dr. Sharmin Ahmed, she is one of the dynamic oculoplastic surgeon in Bangladesh, young surgeon, and she is the consultant of Bangladesh Eye Hospital Institute and Bangladesh Eye Care Hospital. Please share your screen.
Sorry, it's not sharing.
Has she given up already?
No, I think there is a blue button, not blue, there is a green button of share screen.
Yeah, but is it share? No.
No, we cannot see it. It's not visible now. Is the presentation in your desktop?
Yes.
So,
but I don't know why it's not sharing.
Press the share screen.
Yeah, I have pressed, but I don't know.
Do you want to go without the slides? You can put forward your points without the slides as well.
Sorry.
So
what
press
is happening
share
when
the
you are
screen.
sharing? When you
Press
are
share
sharing
the screen, please. Press the share screen button, please.
Yeah, I have pressed already, but it's not coming.
What does it show when you are pressing?
Wait. এটা হচ্ছে না কেন?
কোথায় শেয়ার করব?
Looks like
So
we're
we
in
can
short
just-
drinks break.
Yeah, it's a strategic timeout maybe.
So whether if she cannot share her screen, she can talk directly. What are the points in favor?
Exactly. Yeah.
You can.
Yeah, even I mean, she can see her own presentation on screen and at least talk about it.
Yes, yes.
Even if we are not able to.
Okay, Sharmin, you start and you see your presentation and you just talk.
Yeah, Dr. Sharmin, you can start now. Please unmute yourself.
Or if Sharmin can even email it to somebody, one of you, and then to maybe Ashraful and
Anyone
Can we
but
move
Puneet.
on to the next? Maybe Dr. Sharmin, do you want to email it to me? I can play it for you if we move on to the next.
Dr. Sharmin, please unmute yourself. We cannot hear you.
Okay, I mean, I can say
Okay.
without slide. What?
Perfect. Perfect.
Okay, please start.
Okay, then sorry for the trouble. My topic is management of ocular surface squamous neoplasia. What is the choice of treatment? The choice of treatment is surgical excision with wide margin, no touch technique, and a cryotherapy has been the traditional gold standard treatment. And the benefits of surgery over only topical drops. What are those? These are we cannot diagnose OSSN without any biopsy. We cannot be confirmed because only by history taking like fair screen or sun exposure or having immunocompressive drug, we can be confirmed about the diagnosis. And then when we do clinical examination, it is usually gelatinous papillary, it is leukoplakia or opalescent. It may be flat or raised, or there may be feeder conjunctival vessels. But it is very similar to pterygium, so we can't be confirmed about the diagnosis yet. And the imaging model is if we do some investigation like OCT, but it can only assess superficial tissue and unable to discern the depth of involvement. And if we do confocal microscopy, it is very difficult in use and it have limited field of view. And we can also do high frequent ultrasound. But these machines are not available in everywhere and these are also costly. And after that, if we do the investigation, the diagnosis is still questionable. Now, if we do surgical excision, let's see what are the benefits. We do no touch technique so that the dysplastic cell can't spread. 3 to 4 millimeter uninvolved conjunctival margin is excised to make sure that there is no more dysplastic cell. Absolute alcohol is applied to the cornea to lose the epithelium from the basement membrane and wash with continuous irrigation after 30 to 40 seconds. All involved corneal epithelium and any associated nail penis is scraped off with beaver blade or surgical sponge to ensure that there is no more dysplastic cell. A double or triple rapid freeze thaw technique cryotherapy is applied to the conjunctival aids, involve limbal zone and the bare scleral bed to kill any remaining dysplastic cell. Then we left it open or on conjunctival autograft or emanating membrane graft is done. Then biopsy is done to confirm the diagnosis. What are the other benefits? Like surgery can be done in any rural area where drops are not available, and patient get cured within a short period of time. No need of long-term treatment. It is cost effective. It can be done in large and recurrent tumor, and no need of refrigerator for drug preservation. And it is free of the side effects of drug, which have already Dr. Punit mentioned about the side effects of drugs. So I'm not telling this. And so we can avoid all the side effects of drug by doing surgery. And some studies like Christina S. Moon have said that the efficacy and the cost is equal in case of both surgery and topical drop use. And there is the number of visits to the hospital is less in case of surgery. And Afsana A. Nanji said that the recurrence rate, there is no difference in surgery and the topical drop. And Amber Starch said that in primary OSSN, the effectiveness is equal in case of both surgery and using topical drop, only a topical drop. So the surgery is the best option for whom? For the patient who have localized lesion where the diagnosis is questionable, and in case of large recurrence OSSN and patient who is not able to put drop regularly, and the patient who cannot visit regularly in a regular interval, and where the drops are not available. So why not go for surgery? Why should we wait and carry the tumor cell for the long time where there is the instant cure? Thank you.
Thank you, Dr. Sharman. Dr. Puneet, your comments on that?
So I think I counteracted most of the points already in my PPT. First of all, I would like to point out that we have impression cytology in which we need not to do a biopsy if we are so unsure of the diagnosis. Secondly, in more than 90% of the cases, the diagnosis of OSSN is pretty straightforward based on clinical criteria like feeder vessels, intrinsic vascularity, and overall appearance of the lesion, it being a papilliform or a gelatinous lesion. In clinically indeterminate lesions, obviously we would not be going ahead with topical chemotherapy and might like to biopsy, might like to do an excision biopsy. That said, that the patient profile might still not be suitable, and I might like to give a therapeutic trial of interferon because that has no downside even for 2 weeks. The interferon responds pretty fast, and you do see a response in 2 to 3 weeks. If there is no response, then I will obviously give the choice to the patient. Thirdly, as for the cost effectiveness, the studies that she has quoted are all from the Western literature, where cost of interferon cycle, the entire cycle in India is equal to cost of one injection there, right? So comparing the cost effectiveness, definitely topical chemotherapy in Indian subcontinent wins hands down. Thirdly, she said that it is very difficult to have expensive machines like ASOCT, but the cryo machine and a OT setup and a microscope will equally add up to the entire cost of the setup. And fourthly, there can always be a variation in the technique of the surgery, which would, hamper the eventual outcome for a patient. And lastly, I think that concludes it.
Thank you, Dr. Puneet. Dr. Sharman, any points do you want to?
Yes, because in our country, we don't have the drops availability, and the patient came from very long distance, and the surgery instant, they will not return again and come to follow up. Very sincere patient actually, and the drops are not available in our country, so we have to do surgery at first. Thank you.
Thank you so much. Now, may we have our umpire, Dr. Rakshan Nair.
Thanks. I'll try to make my comments shorter than any of these talks. I think there are advantages on both sides. Surgery is effective. In a single attempt, a single go, the patient becomes cancer-free. There is no doubt with histopathological evidence that the patient is tumor-free, and you know for a fact that it is cured, even if there is, some amount of invasiveness. Also, on the other hand, there are certain disadvantages to topical therapy with interferon also. It is not ideal for invasive tumors, immunocompromised patients like HIV positive patients, or patients who can't keep coming up frequently, or patients who lack the ability to have temperature control over their drops. These are certain dicey cases where you may not think of giving OSSN. But at the end of the day, if it is an isolated lesion and in an immunocompetent patient, where there is a discrete limbal mass or a corneal extension, I think most of us would be right in attempting or prescribing topical therapy first. My only, complaint, not complaint, or rather lament would be that while interferon drops are not easily available, getting a trained ocular pathologist to give you margin clearance and base clearance on your specimen is even more rare. And while Puneet nicely shared Paul Finger's paper on how topical therapy is effective, he chose not to share this paper, which is of super thick amniotic membrane reconstruction for OSSN. So a little selective sharing there, but I would agree this round goes to topical therapy. If I had an OSSN, I would try interferon first.
Perfect. Thank you so much, Dr. Akshay. Namrata ma'am, your comments?
I think I will not give comments on this, Devakant, for the simple reason that Puneet has been my student, and so it will not be fair to, give comments, and so I will reserve my comments. But I mean, if that is not going to influence, I mean, it should not influence the decision. So I, in fact, wanted to admit this in the beginning. And I do agree with Akshay that if it was my own eye with OSSN, although I know that excision biopsy with tumor-free margins would be an option to go for, but I will still try, topical drops, or even for any patient, would still try topical drops before you finally go on to the surgical excision.
Thank you so much, ma'am. Shafruddin sir, your comments?
Yes, nice batting by both the players. I thank all of them for excellent points, but I will say that in Bangladesh and India, there is a variation. In Bangladesh, these drugs are not available, which you told interferon. So in this case, Sharmin will go directly for surgery. And if drug is available, Punet, you will go for a drug first. So in this regard, I will say that the patient, number one, there should be the choice of the patient, what he wants. And number two, the cost of the drugs which she can give. So first of all, I told you that the patient's compliance as well as his how he can manage the cost of the drugs. In this case, we will go for surgery. So I am in favor of Sharmin, and she has mentioned very nicely, even though we have not seen in screen, but she has given the good points. Thank you.
Dr. Sharman has batted without a bat today. So, Ava ma'am, your comments, please.
Yes, thank you. It's really very nice, as because Sharmin was in difficult situation, could not show the screen, but still, ultimately, she did it nicely, and we can understand everything from her presentation. But it is really very difficult situation, as because knowing it fully well, when a patient knows that he or she has malignant condition in his eye, and still we are giving topical drop, topical medicine, and wait for some times, and ultimately then go for surgery. It's not the fact that whether Bangladesh has this drop or not, we will not deal in that way, as because here this is a debate, and what is the ideal that should be come first, not that it is not available in Bangladesh. But still, this is a very important thing that I know in neoplasm. Yes, if it is really the person are very much no compliance is there, and he's very nicely used the drop. What drop it is, it will be 5-fluorouracil or interferon or other, but still I will go for the surgery as because to cut, we know it very well that the neoplasm or tumor or cancer, whatever, in which way we mention that should be removed first, and that is the usual way, and then go for the histopathology and exactly know the thing. So in this batting, I will go for Sharmin, and surgery is the choice of mine. Thank you.
Thank you so much, ma'am. Dr. Ashraful, what do you say?
Thank you, ma'am. So will it go super over at toss again? So I think it's 2-2. So Professor Abha Hussain and Professor Namita Sharma, madam, Professor Sharfuddin sir. So what is it? What will be the final decision?
Ma'am is off as because Punet is her student directly. So in this case, I think we can go in favor of Sharmin.
I think Dr. Puneet, you should send some drops to Dr. Sharmin.
I think I'll do it right away. I'll FedEx the drop tomorrow morning.
That when we repeat the session, then you will win that way.
So thank you very much. It was an exciting session and it was an exciting over. So Divakant, can we move to the last over?
Right, let's move to the pediatric ophthalmology. And may I invite Dr. Niluparna to share her screen first?
So please share the topic.
Yeah. Okay, so we'll be talking about pediatric cataract, whether at the age less than 1 should an IOL be implanted or not. And from India, Dr. Niluparna will be batting. She is a pediatric ophthalmologist from Sri Shankadev Netralaya, Guwahati, and she is an executive member of the Young Ophthalmic Society of India, and she chairs the Assam chapter of Young Ophthalmologist Society. Dr. Niluparna?
I am unable to unmute.
We can hear you. We can hear you.
We can hear you. Unmute yourself.
No, Nilutpurna has now muted herself erroneously. Now we can hear you.
Can you hear me, ma'am? Yes, sir.
Yes, we can.
Yes, but I can't see my presentation. So can you see my? Can you just see my slide?
Yeah, we
everyone-
can see it.
Okay, thank you so much.
Put it in presentation mode.
Okay.
Yeah, put it in full screen. And
So is it okay now?
yeah, our all hopes are on you, Dr. Niluparna.
Yes, I mean, my friend just passed out with that LBW. I don't know. I mean, I'm a little scared, but I'm going to try my best to win this match over Bangladesh. So the topic here is pediatric cataract at age less than 1 year. Should I go ahead with an IOL implantation? And I have no financial disclosure in this presentation. So I would like to answer the queries in terms of the 6 balls that will be served to me in the last over that is given to me. So my opening remark is, we all know that childhood cataract accounts for 5 to 20% of pediatric blindness worldwide. So why not aid the amblyopia treatment by eliminating the periods of uncorrected aphakia? We have all seen by the survey of the American Association of Pediatric Ophthalmology and Strabismus that the number of patients that has been operated below 2 years itself has shot up from 12.9 to 81.9%. So if it is a full toss that you are going to give it to me in terms of visual acuity, citing the IATS report, where they had said that 38.6% of infants who were treated with contact lenses for aphakia had a best corrected visual acuity of more than 20/80 in a median age period of 4.5 years. I would say that the very Indian study that has been done by Ramesh Kekonaya et al. In a 3-year period, they also had shown encouraging visual results of 38.7% in eyes with bilateral cataract surgery in children who were less than 1 year of age. So this is a googly ball for everyone. I'm going to really work on this on a back foot. That is, biometry and IOL power calculation is pretty unpredictable in children, and especially in those who are less than 1 year of age. But if given a choice, I would go ahead with the SRK2 formula because it will give me absolute prediction error, which is better than the other formulas because they are not affected by the factors like age, keratometry, and axial length of the patient. Now, myopic shift is the yoker. So here I will play with some amount of resistance, but I'll try to score it as far as possible because there are different studies, both Indian as well as international studies, and even the largest studies, that is the IITS, which showed that the axial length elongation was lesser in phakic group compared to the pseudophakic group. But if you look at the number, it is 0.17 millimeter per month compared to 0.24 millimeter per month of axial length elongation in the pseudophakic group. So in the study which was reported from India, they showed, we all know that there is a myopic shift which occurs in the first year of life, which is exponential. It is 1.3 at 6 months, then 1.1, and slowly it progresses to around 2 millimeter. Progresses by 0.03 by 2 years of age. So I would not wait for 1 year, but rather implant an IOL with an undercorrection accordingly with the +6 or +7 diopter correction. Now this is an orthodox spin, which was earlier very much feared about by the specialist, but now it has become very handy because if you have the right technique, you can really give it a shot with a boundary or a 6R, because you see, if your IOL is placed in the correct position or you have an optic capture and you have done an adequate anterior vitrectomy, then you will not end up with a VAO. And also the IOLs that were used earlier, hydrophilic, has been replaced by hydrophobic, so you don't have deposits on them. The length ball is glaucoma because it has remained really difficult for us to see that the glaucoma that has progressed cumulative 63% by the end of 10 years. But then there are reports and studies which have said, and even in the study by Kikone et al., they have not encountered any glaucoma patients in their study because it exerts a protective effect against glaucoma development if you implant an IOL in the child. So my clincher here is the half poly, that is the last ball that you have given me. I would say that primary IOL implantation in selected children without anterior segment dysgenesis or glaucoma, having an appropriate corneal diameter and an axial length, and in experienced hands, it is very safe to implant an IOL below the age of 1 year of age. And being in a country which is a developing country, and the study from a developing country itself, where Gorgate et al. Has said that almost 79% of the children are lost to follow-up, then why not implant an IOL? So I would like to ask my counterpart, would you like to go ahead at 1 year of age, or maybe if the child comes back to you at 2 years of age with this kind of cataract, and you have no choice but to leave the child aphakic and have the entire disability adjusted life year of the child increased? Or would you like to have happy children who have been implanted with IOLs at age which are younger than 1 year of age, and then you have just changed the disability adjusted life years of the children by your contribution of just 1%. So I would like to thank the group by saying that your living is determined not so much by what life brings to you as by the attitude you bring to life, not so much by what happens to you as by the way your mind looks at what happens. This is a quote by Khalil Gibran, and I hope I have changed the attitude and to have a good new experience of implanting IOLs in children less than 1 year of age. Thank you so much. And I have this consent from the patients whom I have shown, and these are my own patients. Thank you for your patient hearing.
Thank you, Dr. Nilatparna. Now I would like to invite Dr. Mamun Rashid Chaudhary for his talk. So it was a batting by Dr. Nilatparna. So the last over, our googly bowler, Dr. Mamun.
Just stop
yes,
the screen
Mamun.
share, Nilatparna. Stop your screen share.
Yeah, I'm trying to.
Yep, please.
Yeah,
yes.
I stopped it. Dr. Mamun, you can share your screen.
Okay.
So Dr. Mamun Rashid Chaudhary, he is the consultant pediatric surgeon of Ispahani Islami Eye Institute and Hospital.
Are my screen visible?
Yes. And you are audible too.
Okay. Thank you, BIOS and YOSI, for giving me the opportunity to talk on pediatric cataract at age less than 1 year. Should an IOL be implanted? Actually, my fellow colleague has made my job a little bit easy because the same study, same landmark studies, I have also used in my future slides, and let's see what verdict can we get regarding not IOL implantation. So regarding pediatric cataract management, the two things that comes up our mind, first of all, it is that what visual outcome can we give to the child after surgery, and whether we can avoid a second surgery or not. So does primary IOL implantation in such young child gives a better visual outcome? If we go through the two landmark studies like infant aphakia treatment study and IOL under 2 study, the answer that comes up is no. Why it is no? Because the IOL that we want to put, the calculation of that power is difficult. It's doubtful because of the axial length, because measurement of axial length and the GA, we all know the pediatric ophthalmology is very difficult, and the keratometry errors are frequent in such steep corneas. Even if we can get an axial length and keratometry, the formula what will we use becomes difficult, because all the standard formulas are adult formulas. No clean-cut consensus about pediatric cataract formulas has yet been developed. So if we go through different studies like Kekuni et al., who have compared Hoffer-Q, SRK2, SRK-T, and Holiday 1, and found that all formula gave some prediction error of about 2 to 4 diopters. Nihalani et al. Told Hoffer-Q gave least prediction. ITS said go for Holiday 1 or SRKT, and Trivedi and co-authors said Holiday 2 is the best option. So there are so many variations. Vazavada et al. In their review article has told that all modern IOL power calculation formula gives some prediction error in such young child. So it's a difficult. Even if you put an IOL, the things that you have to counter is visual axis opacification. Even we can go back to IHS, it showed higher percentage of visual axis opacification in IOL group, that is 40%, which is in contrast to only 4% FAK group. Moreover, in our region, the patients tend to follow up infrequently. So whenever you don't know whenever you visual axis opacification has been developed or not, which will make things even more worse. Myopic shift is another threat. 3-child in IITS study has required IOL exchange for large myopic shift. Glaucoma, for a long time, it has been told that FAK glaucoma is a threat, but TAPS study and IOL under 2 study both have told that IOL implantation is not protective against glaucoma. Moreover, there is chance of severe inflammation and postoperative longer steroid use. Now, if we come to that other point of avoiding second surgery, does putting IOL gives us that advantage? Actually, no, because 72% of the child in IOL group, according to IITS, required additional surgery either only for glaucoma or visual axis opacification or for any other lens dislocation or something. But in FAK group, only the rate of additional surgery was less, that is 21%. And even IOL under 2 study also showed higher percentage of patients that required additional procedures for both bilateral and unilateral pseudodefects. So to summarize things, that the main thing that we look, visual outcome is similar in both the groups. So why such doubt and enigma where we need to put IOL power that has so many doubt around it and gray area around it? And moreover, experience and surgical expertise is needed to put IOL rightly into the bag in such younger children. These are my references. At last, it is always better to have a baby's feet in a adequate shoe at the right time rather than in a large shoe. Thank you all for patient sharing.
Dr. Devakan, please unmute yourself.
Yeah.
Devakan, please unmute yourself.
Devakant is on. Nilutparna, would you like to counter that?
Yeah. Yeah, can you hear me now? Yeah. So I was not able to unmute myself actually. So thank you to Dr. Mamanur for his presentation. But I would like to counteract by saying that the studies that you have quoted are all the previous studies, that is the IITS studies, and we have come way ahead of the IITS study right now. And I feel that the studies that have looked at the prediction errors of all the formulas will always remain, even if the child is operated after the age of 1 year. But you see, the amount of amblyopia that you will be having in the children will be very, very restrictive. That is, you will not be able to treat the amount of amblyopia in the children. So why not go ahead with an IOL implantation? And in consideration to the point that if you implant an IOL, you are going to end up with complications, then I would say that especially the visual axis opacification, and even pointing out that this children will not come for follow-up, I would like to say that if you have an adequate vitrectomy and you do an optic capture, then why not go ahead with IOL implantation in children? And if you really want to put the right shoe at the right time, then I think the surgery should have been done beyond 2 years. But by 2 years of age, the child have already exceeded his first growth spurt. So you are actually treating a child who is densely amblyopic, and you are only doing it for the sake of the surgery rather than treating the child for the vision.
Any comments from Dr. Mamanur? Last comment.
Hello. Am I audible? Hello.
Yes, you are audible.
Yes.
Yeah. Yes. Thank you. Thank you. Actually, whenever we talk about putting an IOL in a pediatric cataract, although it is a T20 match, rather I will always opt for a test match rather than a rock and roll T20 match, because in pediatric, such young child, I always prefer for a planned second surgery, not an unplanned surgery which may bring up anything in future. And if you look at the studies, the Vasavada et al., the review article, this is a recent study, and he has concluded that almost all modern IOL power calculation formula has prediction errors. So some forms of refractive error may be there, and also IOL is the main thing you are putting, but you are in doubtful in a gray area about that. So it's a kind of threat for putting an IOL in such young age.
My question would be, even if you're putting an IOL when the child is, say, 13 months or 14 months, would your prediction error go down?
Dr. Mamun?
Please, ma'am, can you please?
Yes, Dr. Mamun, my question is, if I am not putting the IOL when the child is 11 months old, but I'm putting the IOL when the child is 13 months old, do you feel that the prediction error will go down in terms of IOL implantation? It will never go down.
Time, okay, but that time you can have some idea from the refractive or the spectacle you are giving, the refractive status you are seeing, and with time you can have a good axial length, you can measure axial length in a more favorable way. So things may be in your favor when the patient is little bit older.
So I would say that the axial length measurement at 13 months will also be under GA. So how can it be favorable?
I think your point is.
And the axial length
and
the axial length will be adequate by the age of 2 years only. So I would rather do it at, when the child is 25 months.
Actually, if I don't.
And there is no refractive error. And there is no refractive error in cataract.
Actually,
so you cannot predict the post-op refractive error.
I think we are talking. I think we are talking about the patient under 12 years. Yeah.
Both players need a time, but both players.
I am not run out. I have just hit the ball over the stadium.
Okay, just I want to make one point, that is, if I make a patient aphakic at 10 months, I'll not be going to put IOL in 13 months in that patient.
Yes.
Definitely, I'm not going to put IOL just after 3 months. Actually,
yes.
So but I'll rather wait.
Yeah.
So I think both players have made points.
So if
their players now, let's.
Yeah. So the point is that if you are putting making the child aphakic, and then you are putting the IOL later on, I really welcome the point, because as a pediatric ophthalmologist, that is true. But the point is, if you look at the IITS study and the long study that has been done in a developing country like India by Ramesh Kekunaya et al. In LV Prasad for 3 years post-op, the encouraging visual acuity results are encouraging. In a sense, they are equivalent to 36.8% at the end of 3 years.
So Nilotparna is
But
not.
another thing is that IITS study has been done around, I
We
think,
have to win
around
this.
10 countries. So many institute, not only one institute. IITS has been it has been done several institute, and it has been followed up for so many years. So I don't think only one study from one institute.
I think Dr. Mamnoor, we've got your point. Both your points have been well taken, and now it's the umpires to take over. And this is a tough umpiring for me to do, because this is the last over.
I'm so happy I don't have to say anything on it.
It's coming to the third umpires, ma'am. This is very much coming to the third umpire. It's the last ball, and they want to know whether it was a run out or it was that one run which has won the match. So, before I do that, since this has reached this site, we'll give both the captains one last statement, and then we'll close, with the result on this. So, Devakant and Ashraful can give one statement on this point.
You get the ball in their court, very smart.
I'm a retina surgeon, so I have no say in this. Dr. Digvijay, you please take over. So I think the reason we chose the topic and what we were mentioning here was 1 year, and why we did not say that would you put an IOL at 1 month, because that would have been a completely different topic altogether. And while both the presentations were very good, and neither of the players want to let go of the match at this last moment, so there will be appeals. And so the third umpires, be ready. I am coming to you. On my front, I feel that in a child who is kind of beyond 6 months, closer to 1 year of age, I do err on the side of putting an IOL in our situation, considering that the follow-ups are, very often not there. And we've seen very dense amblyopias, and you've done a cataract surgery, and yet you've achieved not much for that child. However, if I've been operating in the first 1 or 2 months of age, or less than 6 months, where the complications are much higher and the predictabilities are very low, that's when I tend not to put an IOL. In that case, I plan a secondary IOL, because you would have done a better job for the child any which way by using a aphakic contact lens, which we often do. And in my practice, in a private scenario, we do get parents who are very compliant with how we do. So suppose that's what the scenario would be. But very well presented, both of you. I think Nilotparna has a slightly upper hand, but I'm going to refer this to the third umpire. So that's the sign there. So we can start with Abba, ma'am.
Madam, please unmute yourself.
Yes, Shafuddin.
Yes, madam. Okay, madam.
Very exciting, very exciting.
Exciting. I think both of them are good batsmen and batswomen. Now, I will say that within 2 months, we have to operate if it is bilateral congenital cataract. And if it is unilateral, we will do as early as possible. That is, within 2 years, we will give IOL. Before 2 years, if you want to give IOL, there will be much more complication, and there should be some glaucoma and also reaction of the IOL. In this case, I should say that he will make it aphakic, and secondary IOL will be given later on, if it is below 2 years. In this way, cataract in the children can be managed. And both of you has given your points, valid points. And in this regard, why you have already, Nilotparna, you told that it is why not in 13th month or not 15th month.
Yes.
I think up to 2 years, before 2 years, we should not give the IOL because of, you have already mentioned that because of reactions and also myopic shift. So I will say that it should be within 2 years, not before 2 years. At 1 year, no IOL should be given to the children. That should be made aphakic. This is my comment.
Thank you, sir. Ava madam.
No, Namrata. Namrata.
Abha ma'am, how are you, ma'am?
I'm good, Nilut.
Happy birthday, Namrata ma'am.
Yes, we have already celebrated. Namrata.
It's been the most interesting.
This is very exciting. Only one run. Only one run.
Yeah, this is very
difficult situation.
Very interesting.
Please, Namrata.
I think as
Very right, very interesting.
as far as the age for the IOL is concerned, it is going to vary a little bit. When the infant aphakia study came, they said that don't give anything in less than 1 year. But I know that in my own institute, it's kind of a split in the sense that if it is, less than 4 months, they will not give it. But if it is more above 4 months, they will put an IOL. So
Yes.
between 4 months and 12 months, they will still put an IOL. So, we don't wait till 2 years because of the fact that myopia can set in. And more so if it is a unilateral one, then we'll run and go and put a IOL because you don't want any anisometropic myopia, there. So, I think I will go with Nilut Purna.
Thank you.
Ava madam, please.
Real difficult situation. There are real debate, both the players very nicely, very exciting. We enjoyed.
Yeah, between the players and between the umpires also.
Session, really. Who own, who not, that is not at all a fact, but the way they are debating, it really an inspiration for all and all the viewers. So there are, of course, debate there, whether it will less than 1 year or more than 1 year. And third umpire has already declared that after 2 years. Everything has their point, as because aphakia will not be there. That should be corrected by spectacle, and no way of contact lens or other. So if we did surgical extraction of cataract and just wait for to avoid the amblyopia, we can give the spectacle, and that was the usual thing earlier. And nowadays it is, of course, there are some surgeon and very skilled surgeon and very what I said, that they want that there should not be a single day no amblyopia in that, and Nilut Purna has said it very clearly. But still we should think what will be the condition of that child after giving the implant. What will happen? So thinking all be better to give ours. Again, I will say that Nilut Purna has asked repeatedly to Mamunur Rashid that whether what will happen in 13 months, in 14 months, in 15 months. Yes, of course, that is a very important issue. But still, what we think that we will not wait for the amblyopia. We'll treat the amblyopia during that period, and we will go for. Everybody is looking at me.
Yes, ma'am.
What
Yes,
you
real
want?
decision pending.
Let me. This is really a very good debate, and what we want, the BIOS and YOSI. Excellent job, and I would like to express my heartfelt thanks to Dibakant and Ashraf, as because really Ashraf is thinking in that way that whether I will be here today, as because there are some problem with me, and still I was thinking that this is a very good session. This will be a very good session, and I will never say no I will never say no when Ashraf asks me, Madam, please request me, Madam, please, if possible, you please come. And just before 5 minutes starting the session, he again phoned me, Madam, will you, all right, whether you will come? I said yes. So if it is, we like that, same, it's equal 3-3 as because Bangladesh is, Bangladesh 3 is to India 2. And if now India own the game, then it will be 3-3. I must say that
Niluparna won the game.
Yes, we'll do implant for 1 year and Niluparna owns the game.
Thank you, ma'am. Thank you.
all.
I love you, ma'am. Thank you so much, YOSI and Bangladesh Society. Thank you.
Thank you.
Congratulations,
No, I'm
Dr.
not,
Mahmood.
nothing else but take care to that child, with that everything is fine.
Yes, I will recently publish my data of 3 years. I will recently publish that.
So officially, Niluparna, you won this round. So
Thank you
it's
so
a tie for India and Bangladesh.
Yes,
And,
total
Yes.
tie.
First game is tie.
Thank
Now
you.
a super over between the captains.
Thank you. Divakant, over to you, please.
Yes, so this is all we had hoped for, an exciting finish, and a tie is always welcome. So this means we'll have to organize another session where we can have a decision. So, Dr. Ashraful, your vote of thanks, please, before, and any comments from the third empires or
I
empire?
think on behalf of YOSI, I would like to thank Dr. Ashraful to have us, as a part of this BIOS YOSI session. I mean, we are very happy to, that you've decided to have us as a part of it.
And also,
I would like to thank the captain, of course, the captain, and all the umpire and the third umpire, and all the batsmen and batswomen, as because this is an
Yes.
excellent.
Another word is here.
I
the
didn't see
batswoman.
this sort of session till this COVID period, and this goes really. This is exciting. The last batsman deserve thanks, and all the batsmen deserve thanks, and thanks the judge and thanks the umpire. Thank you.
And special thanks to the organizers for having chosen wonderful topics that got such a great debate going in every specialty. So hats off to Ashraful and Divakant.
Yes, every specialty have been covered. That is
Actually,
the bat
this is
and
very
ball.
important. And this
the
is very
selection of the
important,
bats
because
and balls are very good. And I
Yeah.
think Ashraf and Divakant, they have a good thinking, good vision. That's why they have arranged such excellent debate. In future, we are waiting for another one, as because today there is tie. In future, everyone should be prepared that another one set of players should win. And this way, everyone, both from Bangladesh and both from India, they should be prepared. I thank all the speakers, all the panelists, all the moderators, that is umpires, and also the captains, along with the speakers. Thank you very much.
I think I'd also like to thank Professor Namita Sharma, who on her birthday, a very special day when she's with family
Oh, yes.
at home, is taken out time to come here for this session. It's really, ma'am, amazing.
Thank you.
Thank you, Digvijay. The only thing I told Devakant was I will go early, but it finished on time, and it was one of the most interesting debates I have ever come across. Really.
Yes,
The best
same
part
to you.
about these young people are they're perfect on time. Their comments are crisp. They will just speak what is required, and it was just a smashing hit. I mean, you should archive it, and I can't organize one more.
Thank you, ma'am.
And when it came to Professor Ava Hussain, ma'am, I knew she's going to make it a tie. I know that she's not going to keep it one side.
And she will not leave.
So
until
that
it
is
is
why
ended.
I said one side, and as soon as Dr. Sharfuddin said one side, I said one side, and then put the ball in her court.
Thank you, madam.
Thank you,
Professor
madam.
Namita Sharma, happy birthday to you.
Thank you so
Yes.
In the
Thank you,
event.
madam.
Happy birthday, Namrata, once again.
Thank you. Thank you, Namrata madam. Happy birthday from Bangladesh Young Ophthalmology Society to you, ma'am. And there is nothing left to say. The one thing is that the debate format and everything, me and Divakant was planning from the September. And thank you, Divakant, for this exciting session. And thank you all the YOSI members and all the BIOS member, and also our respected advisors, our respected patrons, and the present umpires and third umpires. And it is not the last. Hopefully we will do lots of things in the next year. So Merry Christmas and Happy New Year for 2021. And we are looking forward to do another great webinar in 2021. Thank you very much.
Thank you, Ashraf.
Thank you.
Good night.
We need to play on the field as well.
Thank you.
Okay,
Yeah,
thank you.
definitely.
He
We're
will
looking
play in the
forward for
field.
it.
Fine.
Thank you all. Thank you.
Thank you.
During this game, there was no injury to the eyes.
Yes.
Right.
No, today one of our